So now these 2 days, I'll be discussing the nephrology. So the first topic for the session will be the basic introductory topic, that is the urine analysis. And followed by the urine analysis, then we will be discussing the acute kidney injury and chronic renal failure, renal replacement therapy, nephrotic syndrome, nephritic syndrome, renal tubular acidosis, then genetic disorders of the kidney. So these will be the topics for the discussion, and even I'll be discussing the renal stones as well. So is the surgery over for you? Yes, surgery, general surgery. I mean, in the sense, surgery. Okay. So is the topic of the renal stones done there in the surgery? Okay, fine. Right. So in this session, so if renal stones are done, then I will not touch upon that because they might have been dealt in detail in surgery. So now the first topic, it is urine analysis. Right, for acid-base disturbance and electrolyte abnormalities, we have a separate session. I'll not be discussing that under the nephrology because that is completely a separate session for you. That is electrolyte abnormalities and as well as the ABG, arterial blood gas analysis. Now, so in the urine analysis, what does the urine of a healthy individual contain? So urine of a healthy individual, it contains a small number of cells, right? Along with that, you have some formed elements, right? You have some formed elements in the urinary sample, and this small number of cells, or you take the formed elements, they can be present anywhere or they can be produced anywhere in the genitourinary tract. Okay, now what does this small number of cells contain? Like, what will be the cellular elements? The cellular elements, either it could be RBCs, right? So how many RBCs? Less than 3 RBCs, if they are present, then they're considered to be normal. There can be few WBCs and few epithelial cells. So these are the cellular component in a normal urine analysis. Whereas you take the formed elements, right? What would be the formed elements? This would be cast, right? Or this could be even the spermatozoa in males. Okay, this is what the normal urine analysis will be. But what about the specific gravity? What about the pH? What about the osmolality? I'll be discussing that subsequently. But what I'm talking about is the normal urinary content. Now, what does the abnormal urine analysis will be? So if you take the abnormal urine analysis, which we consider it as urinary sediment, abnormal urine analysis. So what all will be there in the abnormal urine analysis? In the abnormal urine analysis, as usual, same. You will have the cellular elements, but these cellular elements will be present in greater quantity or greater extent. And what are the examples of the cellular elements? These cellular elements, they include RBCs, but the number of RBCs will be more than 3. WBCs, or even it could be presence of the epithelial cells, right, which is nothing but the malignant cells. Okay. And the another important abnormal constituent will be presence of abnormal cast. There can be even normal cast also. The normal cast is nothing but the hyaline cast, which I'll be discussing that in detail, but there can be presence of the cast as well. Then there can be presence of crystals, right? Or there can be even presence of bacteria. Okay. So this is what is the constituent of the abnormal urine analysis. That is cellular elements, cast, crystals, and bacteria. Now, this cellular element, cast, crystals, bacteria, where could be the site of origin? Any of these. This indicates either glomerular injury, or it could be tubular injury also, right? And one more important or few more abnormal constituents is metabolites. What will be that metabolites? Presence of proteins, presence of fat bodies, okay. So these are the abnormal constituents. Now, out of which, what is very important part of the discussion is the proteins. Let me discuss about the proteins first. Okay. So in the proteins, like when do we call it as significant proteinuria, and how much is the normal proteinuria? Right? If you take the proteinuria as such, normal total proteinuria, how much is that? That is less than 150 milligrams per 24 hours. That is a normal total proteinuria. But how much is the normal albuminuria? Normal albuminuria, it is less than 30 milligrams per 24 hours. Right? Now, what has happened with this is the patient has to collect the urine sample for nearly around 24 hours. So there can be mismatch. Sometimes there might be under collection, sometimes there may be over collection, sometimes the sample get contaminated due to any reason. So there is a very high chance that there can be an error when you are collecting the 24-hour sample. Now, in order to avoid this particular error, right, we have come up with spot sample, right? That means in one single urine sample, you will be able to estimate what is the quantity of the albumin that is being excreted. Okay, so the quantity of albumin excreted can be calculated in a spot sample. For that, we have a formula. What is that formula? That is albumin excretion rate. Right? So how do we make out this albumin excretion rate? The quantity of urine albumin by urine creatinine. This will give you the albumin excretion rate. So this will quantify the quantity of albumin excreted in the spot sample. You don't require the 24-hour urinary collection of the samples for this, right? Now, previously, based on the 24-hour urinary sample, we used to give terminology is called microalbuminuria and macroalbuminuria. Microalbuminuria is what? 30 to 300 milligrams per 24 hours. Macroalbuminuria means more than 300 milligrams per 24 hours. That was considered to be micro and as well as the macroalbuminuria. But now these terminologies have been replaced by the new terminologies. What are those new terminologies? Is moderately increased albuminuria, right? And the other one is severely increased albuminuria. Right? Severely increased albuminuria. Right. Now, how to make out, just one second. Okay. So, how to make out moderately increased albuminuria and severely increased albuminuria? So, moderately increased albuminuria. So, first of all, you need to know the units of this albumin excretion rate. What is your albumin excretion rate now? Albumin excretion rate, it is nothing but urine albumin to that of the urine creatinine excretion. So how do we give the units as? We give the units as milligrams. What is that milligram? That is your albumin. Milligram per gram of creatinine excretion. What is this gram? That is your creatinine. Milligram per gram, that is the unit for your albumin excretion rate. So if your albumin excretion rate is 30 to 300 milligram per gram, that is called moderately increased albuminuria. Okay, and these patients previously they were considered as microalbuminuria. So microalbuminuria, right, is that where the quantity of the albumin excreted is 30 to 300 milligrams per 24 hours. This was the previous description. But now what are we using it as? We are using it as moderately increased albuminuria. Okay. Now, what are the conditions where you will have this moderately increased albuminuria? You have that in patients with diabetic nephropathy, right? And you have this in patients with hypertension, and you have that in patients with glomerulonephritis. Okay, so these are the conditions where you will have moderately increased albuminuria, which is nothing but 30 to 300 milligrams per grams. Then when do you call severely increased albuminuria? Severely increased albuminuria, that is albumin excretion rate, it is around 300 milligrams to 3, okay, sorry, 300 to 3,500 milligrams per gram. That is what is the albumin excretion rate in severely increased albuminuria. And one point you should remember is that in case of severely increased albuminuria, these patients, they are at increased risk of cardiovascular mortality. Then what are the causes for severely increased albuminuria? So if you take the numbering as 1, 2, 3 for diabetic nephropathy, hypertension, and glomerulonephritis, the conditions where you will have severely increased albuminuria, that is albumin excretion rate, it is in the range of 300 to 3,500 milligrams per gram, right? Just keep 1, 2, 3. That means your diabetic nephropathy, hypertension, and glomerulonephritis. Even that will cause the severely increased albuminuria. Then the other conditions are multiple myeloma, congestive heart failure. Next, in cases of fever, exercise, and then orthostatic proteinuria. Okay, so these are the causes for the severely increased albuminuria, right? Where the urine albumin excretion rate is around 300 to 3,500 milligrams per gram. Okay, milligrams is your albumin, per gram is nothing but your creatinine. Okay, now, so this is one methodology of assessment of the proteinuria. How much is the normal total? When do you call moderately increased? And when do you call severely increased? Right? Then the other way by which we can make out the proteinuria is there are certain conditions. Okay, what do you mean by the one point I want to tell you about the exercise and as well as orthostatic proteinuria. What is being advised is the patient has to be informed very clearly that we are doing your urine examination. So if you have the habit of doing exercise or morning walking, morning jogging, so please don't do that. Okay, because if you do a jogging or exercise, there is chance that the protein levels in the urine may increase. So please don't do any exercise and then come and directly give the urine sample. That is what is the advice that you should give. Then orthostatic proteinuria. Orthostatic proteinuria is that when the individual is in supine position, when the urination is done, there is no proteinuria. But when the individual gets up and then urinates, there is chance of proteinuria. That is called orthostatic proteinuria. That is called orthostatic proteinuria. Now, your both of these conditions, that is your exercise and the orthostatic proteinuria, both of them, they come under what is called the functional proteinuria. Right? The other way by which you can make out the proteinuria is functional proteinuria. So functional proteinuria means you don't have any pathology within the kidney, right? Exercise, right, or jogging can increase the quantity of the proteins in the urine. Okay, and that we call it as the functional proteinuria. Then we have another terminology called overload proteinuria. Right? So can anyone tell me what is the clinical condition where there is maximum amount of the proteinuria that can occur? Maximum quantity of the proteinuria occurs in which pathological condition? Very good, Jacob. That is multiple myeloma. So multiple myeloma, the quantity of the proteinuria, it is nearly around 8 to 10 grams per 24 hours. It is nearly around 8 to 10 grams per 24 hours. But the total quantity of the proteins in our body is only 6 to 8 grams per 24 hours. But Jacob, like, how can you explain now the proteinuria of 8 to 10 in multiple myeloma? Any one of you? The total quantity of the protein is only 6 to 8 in our body. But why there is 8 to 10 grams per 24 hours in case of multiple myeloma? The reason is because in multiple myeloma, you have abnormal immunoglobulins which are being formed, or abnormal light chains which are being formed. Right? Very good, Jacob. So there is increased globulin synthesis. There is monoclonal proliferation. Very good, Soumya. Right? So because of that, the excess plasma cells will be formed, excess abnormal light chains will be formed, and it is your abnormal light chain containing proteins that will be getting excreted in the urine. That will be nearly around 8 to 10 grams per 24 hours. Then the overload proteinuria can also be seen in cases of rhabdomyolysis, okay, where there is crush injury. Like for example, an individual is crossing the road and a vehicle has passed over his lower limb and completely crushed his muscle. That can result in rhabdomyolysis, where there will be excess myoglobin which will be released into the circulation, and that will be passing through the renal tubules and excreted in the urine. That is, myoglobin is nothing but again protein there. Next is hemoglobinuria. So hemoglobinuria, like you come across this in patients with the hemolytic anemias. Okay, so whenever there is excessive hemolysis, more and more hemoglobin will be released into the circulation, right? And that particular hemoglobin, it is a globin there, right? It's having heme plus globin, which is containing the protein, and that hemoglobin will be getting excreted through the kidney, through the renal tubules, resulting in overload proteinuria. Next, lastly, nephrotic range proteinuria. So if you take nephrotic range proteinuria, how much is that? That is, albumin excretion rate is more than 3,500 milligrams per grams of the creatinine excretion. And what are the conditions where you will have the nephrotic range proteinuria? Right? The etiology for nephrotic range proteinuria will be diabetic nephropathy, then amyloidosis, minimal change disease, focal segmental glomerulosclerosis, then membranous glomerulonephritis. These are the conditions where you will have nephrotic range proteinuria, right? And whenever there is overload proteinuria, then, or in case of nephrotic range proteinuria, in both of these scenarios, there will be frothy or the foamy urine will be there. So whenever a person passes the urine, the froth or foam will be there in all those individuals who are excreting or like just urinating excess amount of urine. But how will you differentiate the foamy urine from the normal urine sample if there is presence of a froth on the urine sample? I hope you have understood the question. Just 1 minute, I'll just open that image for you. Yes, how will you differentiate a urine sample containing excess amount of protein from that of, okay, so you see this urine sample here. Now, this is what is froth, that white color, what you are seeing over the urine sample, that is what is nothing but froth. So how will you differentiate a urine sample containing excess amount of protein forming a froth, and how will you differentiate a urine sample with froth without protein? Without protein. So how will you differentiate is, you need to collect the urine sample, right, and place it in the flask for 5 minutes. And initially you are observing the froth. Initially there is presence of the foam or there is presence of a froth. If that particular foam disappears within 5 minutes, if that particular foam disappears in 5 minutes, then that is considered to be a normal urine sample. Whereas even after 5 minutes, even after 15 minutes, still there is presence of foam within the flask. That is suggestive of the proteinuria. That is suggestive of proteinuria, right? I hope you have understood this point. Just give me a quick thumbs up. Were you able to analyze this? All right. Now, the other point you need to know, that is a question as well. When the urine is exposed to air, right? When the urine is exposed to air, the urine, it turns yellow in color. Now, why is it turning into yellow color? That is due to the presence of an important substance called urochromes that will give yellow color to the urine, right? Then some set of questions are being, how now in the recent days, how is that we are estimating the quantity of the urine, right? We are estimating the quantity of the urine based on the dipstick test, right? Based on the dipstick test. So we give the value as like trace, we give the value as like 1 plus, 2 plus, 3 plus, and as well as the 4 plus. When will you give that? Depending upon what value of the protein in the urine, when will you give 1 plus, when will you give 2 plus, 3 plus, 4 plus? That's a very, very important area for the questions. So the urine containing protein sample and the quantity of the protein in the dipstick, it has been found to be trace. When do you call trace? The urine sample if urine sample contains 15 to 30 milligrams per deciliter of the protein in the urine sample, then we consider it to be trace. Then when do you consider 1 plus? When do you consider 2 plus? When do you consider 3 plus? And when do you consider 4 plus? We consider it as 1 plus when the quantity of the protein that is being present in the urine is around 30 to 100 milligrams per deciliter. And we consider 2 plus when the quantity of the protein is around 100 to 300 milligrams per deciliter. And when do you call 3 plus? When the quantity of the protein is nearly around 300 to 1000 milligrams per deciliter. And when do you call 4 plus? When the quantity of the protein is more than 1 gram per deciliter. Okay, so this is about the assessment of this particular point is very, very important because 2-3 times the questions have been asked, right? If the dipstick shows 3 plus, what is the quantity of the proteinuria? Or they'll give you a complete clinical history and shows that the urine dipstick analysis have shown the dipstick as like 3 plus proteinuria. So now what is the quantity of the protein excreted in the patient's urine sample? They'll give you the options like 30 to 100, 100 to 300, 300 to 100, sorry, 300 to 1000, or like more than 1 gram. Okay, so you should be able to make it out. Now, if you take this proteinuria, we also classify this proteinuria as the glomerular proteinuria and as well as the tubular proteinuria. Right? First point is, what exactly is your glomerular and what is tubular? I'll tell you. But you need to know, normally the proteins, they are not excreted. Right? Normally the proteins are not excreted in increased quantities in a normal individual. How much is that quantity we have discussed? That is less than 30 milligrams is your albumin and less than 150 milligrams is your total protein. So in a normal patients, the quantity of the protein is not in excess quantity. So normal patients, right, the urine does not contain the excess quantity of the protein. Okay, normal patients, normal. So normally proteins are not excreted in increased quantity. Now the question comes, why? Right, now the question comes, why? So the point that you should understand is the glomerulus, it has a barrier for the proteinuria to occur. Right, glomerulus, it has barriers so that the proteinuria does not occur. What are these barriers? There are two important barriers within the glomerulus. What are those? I'll just show you. One is the distance between, right, you see this. This is what is your glomerular basement membrane, right? And these are the podocytes, the red color ones. I'm sorry, this is ulta, right? So these are the podocytes, right? And these are your endothelial cells. Okay, these are the endothelial cells. Now, the image is like upside down, but I'll just make it very clearly. So this is the basement membrane, and these are endothelial cells. And beneath that, you have the podocytes, which are nothing but the foot-shaped processes. Okay, I said you that there are two barriers. One is the distance between the two endothelial cells, that is the gap. How much is the normal gap? Normal gap, it is less than 8 nanometers. But you know the size of the proteins? Okay, so this is another line of your glomerulus. Okay, so the proteins which are present in the glomerular capillaries, that is in the plasma, the size of the proteins more than 8 nanometers. The size of the protein is more than 8 nanometers, but the gap is less than 8 nanometers between the endothelial cells. So because of increased size, the proteinuria does not occur. Right? Because of the increased size of the proteins, the proteinuria does not occur. That is one point. Second important point is, on this particular podocytes, you have a negatively charged ion. Now, what are these negatively charged ions? These negatively charged ions, they are sialoproteins, right? And even your protein is also negative charge. And even the siloprotein which is present on the podocyte is also negative charge. So whenever the protein want to filter through the glomerulus into the Bowman's capsule, right, into the Bowman's capsule, remember, it cannot occur because the negative charge of the siloprotein will repel the proteins to be filtering into the Bowman's capsule. So there are two components now which are acting as a barrier. What are those? Number one, distance between the endothelial cells. The distance between the endothelial cells, it is less than 8 nanometer. Next is charge of the siloprotein. So if you take the distance less than 8 nanometer, but the protein size is more than 8 nanometer, so thereby the proteinuria does not occur. Whereas siloprotein is a negatively charged protein, right? Siloprotein, it's a negatively charged protein. And please remember that the proteins are also negatively charged. Right, the proteins are also negatively charged. Okay, so this negatively charged proteins, they will not be filtering across the siloprotein which is also negatively charged. So these siloproteins, they will repel the proteins from filtering, and thereby the proteinuria does not occur. Thereby the proteinuria does not occur. Okay, now among the proteins, which protein is like excessively excreted among proteins? Predominantly, right, predominantly it is albuminuria. Right, predominantly the proteinuria that occurs is albuminuria among the proteins in a normal individual also. Now the question comes, why? Like you have albumin, globulin, fibrinogen, and many other proteins, but why is it predominantly albuminuria? Can anyone tell me? Anyone? Yes, Jacob. Why it is predominantly albuminuria? Why not the other proteins? Very good, Kamalanathan, right? Very good. So the size of the albumin is 7 nanometers. The size of the molecular size is only 7 nanometers, right? But we have two barriers. One is the size, the other one is charge. So the distance between endothelial cells is less than 8 nanometer, but the size of the albumin is only 7 nanometer. So for albumin, please remember, size is not a barrier. Right? Size is not a barrier. Okay. It is only the charge. Right? Only the charge on the albumin. That is the barrier. So if this particular charge is taken off, either if there is damage to your glomerulus where the siloprotein is lost, then albuminuria occurs significantly then compared to that of any other proteins which are being lost. Okay, now albumin has only one barrier now. Size is not a barrier, only the charge is the barrier for the albumin. That is the reason why in the proteinuria predominantly what you will have is the albuminuria, right? So I hope everyone has understood this. Right, just give me a quick thumbs up if you have understood like why predominantly it is albuminuria. Okay, only Hari Maheshwari has understood. What about others? Soumya, good. Okay. Right. Now, the next important is, I was telling you about the glomerular proteinuria and as well as the tubular proteinuria. Now, what is glomerular proteinuria and what is the tubular proteinuria? If there is any pathology in the glomerulus, right, there is some damage to the glomerulus, and because of the damage in the glomerulus, right, because of damage to the glomerulus, if there is proteinuria, that is called glomerular proteinuria. And one more point you should remember is that there are some small proteins. They can be easily filtered from the glomerulus and they have to be absorbed, right? And they have to be absorbed in the tubules. But if there is any pathology in the tubule itself, then those proteins will not be absorbed. Okay, right. That is called, what is glomerular proteinuria? If there is any pathology in the glomerulus, if there is proteinuria, that is called glomerular proteinuria, right? And in a normal individual also, small proteins will be filtered from the glomerulus and they enter into the tubule. And if there is any tubular pathology, then the proteins will not be absorbed. Proteins will get excreted out, and that is called tubular proteinuria. Okay, so what are those proteins? Right, proteins which are normally filtered across the glomerulus. Right, proteins normally filtered across the glomerulus. The proteins which are normally filtered across the glomerulus are that I said, like there are some small proteins which can get easily filtered. What are those are? That includes number 1, beta 2 microglobulin, right? Then apoproteins, right? Apoproteins. We have some enzymes, then peptide hormones. Okay. These are the proteins which are normally filtered across the glomerulus. And all of them, these proteins, they have to be absorbed at the tubule. Right? They have to be absorbed at the tubule. But right, if there is any pathology in the tubule, then these proteins are not absorbed. And that is called as the tubular proteinuria. That is called as the tubular proteinuria. Okay. And not only that, we have one more protein, that is Tamm-Horsfall protein. Okay. Now, let me try to tell you the differences between the glomerular proteinuria and as well as the tubular proteinuria. Right? Glomerular proteinuria. And the other one is tubular proteinuria. Glomerular proteinuria means where the pathophysiology is at the level of the glomerulus, right? So because of the glomerular pathology, there will be increased leakage of proteins. Right? There will be increased leakage of proteins. That is called glomerular proteinuria. Whereas if you take the tubular proteinuria, so tubular proteinuria is, right? It is failure of tubular reabsorption, right? That will result in proteinuria, that is called tubular proteinuria. Then followed by that, what is the daily excretion of the protein? How much is that in case of the glomerular proteinuria? So that will be more than 3 to 3.5 grams per day. That will be the quantity of the proteinuria in glomerular proteinuria. Whereas the proteinuria in case of tubular proteinuria is up to 2 grams per 24 hours. Right? It never exceeds 2 grams. It will be up to 2 grams per 24 hours. And if you take the protein type which is excreted in glomerular proteinuria, it is predominantly albumin. Right? It is predominantly albumin. Whereas in tubular proteinuria, it is beta 2 microglobulin. Right? Then light chain immunoglobulins. Right? Light chain immunoglobulins. These are the protein types which are excreted in tubular proteinuria. Then you need to know ratio, that is albumin to beta 2 microglobulin ratio. Right? Albumin to beta 2 microglobulin ratio. So this here ratio exceeds, because albumin levels are more in glomerular proteinuria, the ratio, it is more than 1000:1. Right? Ratio is around 1000:1. Whereas in case of the tubular proteinuria, the ratio is reduced. Why? Because the beta 2 microglobulin is the one which is like excreted in excess quantity. So here the ratio is around 10:1. That is albumin to beta 2 microglobulin ratio. Then in which form of proteinuria you have the presence of the Tamm-Horsfall protein. The Tamm-Horsfall protein, you see that it is not increased in glomerular proteinuria. But the Tamm-Horsfall proteins are those which have to be absorbed by the tubules. But if there is tubular pathology, you will notice that there is increased Tamm-Horsfall protein that will be appearing in the urine. Okay, so Tamm-Horsfall protein in the urine. Right? It is your tubular proteinuria. In tubular proteinuria, the Tamm-Horsfall protein secretion that is grossly increased. Okay, that is about the differences between the glomerular proteinuria and as well as the tubular proteinuria. Right? Very simple concept. It is not a difficult one. The glomerular proteinuria pathology is at the glomerulus, tubular proteinuria at the tubule. Glomerular proteinuria, definitely the excretion of the protein will be more, that is nearly around 3 to 3.5. But tubular proteinuria, it is only up to 2 grams. Protein type, predominantly it is albumin because it has only one barrier. Tubular proteinuria, all the small proteins, that is beta 2 microglobulin, Tamm-Horsfall protein, light chain immunoglobulins are these. And if you take the ratio between, that is albumin to beta 2 microglobulin ratio, the glomerular proteinuria, it is 1000:1, but tubular proteinuria, it is 10:1. And Tamm-Horsfall protein, it is more in case of the tubular proteinuria than compared to that of your glomerular proteinuria. Okay, right. With this, we are done with the component of the proteinuria. So what did we discuss? That in the abnormal urine sample, there can be presence of the proteins. Okay, and that is what we have discussed in detail related to your protein. And the next important is cast. Let me discuss about the cast. We are done with the protein component. Now let me discuss the caste, and within the caste itself, I'll be discussing about the crystals also, that is crystalluria. Okay. Then we will discuss your RBC, WBC, fat bodies, and the remaining so on and so forth. Now, first of all, what do you understand by the word caste? The word caste, the definition is it is a protein basically. But how is this protein formed? It is precipitation. So caste is the structure which is formed via precipitation of Tam Horsfall mucoprotein. Right, formed via the precipitation of Tam Horsfall mucoprotein. Right, and sometimes the caste may also contain albumin. Right, sometimes the caste may also contain the albumin. Okay, now this particular casts are formed through solidification of the material. And where are they formed? That is due to solidification of material, where that is in the tubules of the kidney. Right, in the tubules of the kidney. Now, specifically, which particular part of the tubule? That's a multiple choice question. These casts, they are formed in the DCT, distal convoluted tubule, and they are formed in the collecting duct. Okay. That means if there is presence of the caste in the urine sample, that is abnormal caste, that tells you that there is pathology in the DCT or the collecting duct. That's a very important point you need to analyze. Okay. Now, so I said you like solidification of the material. It can be any material. That means RBCs, they can precipitate with these proteins causing RBC caste. WBCs, they can precipitate with these proteins causing WBC caste. Or epithelial cells, they precipitate with these proteins called renal tubular epithelial cell caste. There can be granular caste, there can be eosinophiluria, there can be even crystalluria also. Now, let me discuss about the caste in detail. What are all the various forms of pathological caste and physiological caste as well? So, if you take the various types of caste, so what is caste now? It is formed by precipitation of Tam Horsfall protein, or sometimes the precipitation of your albumin. So, if you take the various types of caste, you need to know the normal caste first. The normal caste is the hyaline caste. The normal caste is the hyaline caste. Apart from this normal caste, which is a hyaline caste, what are the other various types of the caste that can be seen in the urine sample? There can be aggregation of the proteins with RBCs causing the RBC caste. There can be aggregation of the proteins with WBCs causing WBC caste. Okay. There can be granular caste. Right. There can be also pigment caste. Right. There can be also pigmented caste. Okay. And the next important is the broadcast. So these are the various accumulations along with the proteins. What are the conditions where you will have the RBC cast? Okay, this though you should be able to answer. Can anyone tell me what are the conditions where you will have RBC cast? Yes, you might have read this even in your connective tissue disorders also. Very good, Soumya. That is in glomerulonephritis. That is, you take post-streptococcal glomerulonephritis. They will have cola-colored urine or the hematuria, right? Where you will have the presence of the RBC cast. The other conditions where you can have the RBC cast is vasculitis, then malignant hypertension, right? Then we have thrombotic microangiopathy. What do you mean by the word malignant hypertension? Yes. What do you understand by the term malignant hypertension? When do we use the term malignant hypertension? None of you, what is malignant hypertension? No, not 160 by 100. So in case of malignant hypertension, different books gives different values. CMDT gives for the malignant hypertension the value as 220 by 130 millimeters of mercury, right? But the Harrison gives 180 by 120 millimeters of mercury. Whatever it might be, right? Whatever might be the blood pressure. But the point to tell about malignant hypertension is, very good, Vinita, there should be the end organ damage, hypertensive encephalopathy, papilledema, hypertensive heart failure, hypertensive nephropathy. So there should be end organ damage because of that excessive increase in the blood pressure. That is called malignant hypertension. Okay, right. Then in malignant hypertension also, because of your hypertensive nephropathy, there can be presence of your RBCs. Now, you take WBC cast. That means the proteins are aggregating with the WBCs. So can anyone tell me, please, what are the conditions where you will have WBC cast? You should answer this because this is not a difficult one. Very good. So that means there should be some infections. There should be infections. So what will be that infections? That includes the pyelonephritis. But very important area where you can have the presence of the WBC cast is in case of interstitial nephritis or acute interstitial nephritis secondary to some antibiotics, right? Like cephalosporin and all. You can have this acute interstitial nephritis where there can be presence of the WBC cast. And not only that, in case of glomerulonephritis, there can be WBC cast, and even in case of allograft rejection. Okay, so these are all the conditions where you can have the presence of the WBC cast, right? Then coming to your granular cast. Granular cast is that you come across in patients with acute tubular necrosis, and then in conditions like glomerulonephritis. That is where you have this granular cast. And you take the pigment cast. What do you mean by this pigment cast? You have some pigmented material in that. Where can you have? You have that in case of myoglobinuria, and the other condition is hemoglobinuria. So in myoglobinuria, it is due to rhabdomyolysis. That is, the myoglobin is there within the in that cast. That's why it will be like brown color. In hemoglobinuria, you will have dark red cast. That is what is in hemoglobinuria. Then the next important is the broad cast. The conditions where you will, and we have one more pigmented cast, that is muddy brown cast. Muddy brown cast, you see that in case of acute tubular necrosis, right? And then next is the broad cast. Where do you get this broad cast is in diabetes mellitus causing chronic kidney disease. There you can have the presence of the broad cast. And lastly, one important form of the cast, which is nothing but the waxy cast. Waxy cast, you have that in chronic glomerulonephritis. Okay, so basically you should remember what exactly is the cast. If there is presence of the cast within the urine sample, what you should think of? You should think of the pathology in the kidney, that is in the distal convoluted tubule and collecting duct. And the cast is basically the clumping of the proteins, aggregation of the proteins. Predominantly it is your Tam-Horsfall protein, and occasionally there can be presence of albumin. And these are all the various types of cast, right? Normal, RBC, WBC, granular cast, pigment cast, and then broad cast. Then, now we were discussing like the crystaluria, right? That is the presence of crystals also can be there within the urine, right? If you go back to the normal discussion, the primary discussion, we have discussed the cast now. Let me take up about the crystals. What are the conditions where you can have the presence of the crystals in the urine or in the urine sample? The conditions where you will have the crystaluria, can anyone guess and tell me, because some topics in your connective tissue disorders you might have read. What is a connective tissue disorder, or where there is involvement of grade 2 and having crystaluria? I have given you a clue. Very good. That is your gout. So in case of gout, you will have the presence of the uric acid crystals. Right? And you might have read your toxicology, that is your forensic medicine, ethylene glycol intoxication. Can anyone tell me what is the type of the crystals that you will have in the urine sample? Ethylene glycol intoxication. Anyone? In case of ethylene glycol intoxication, please remember it is calcium oxalate crystals. Right, calcium oxalate crystals, you see that in ethylene glycol intoxication. Okay, and even there are certain drugs which can contribute to the formation of the crystals and excreted in the urine. That includes acyclovir, which is an antiviral drug, then indinavir. So can anyone tell me indinavir is which group of antiretroviral drug? Anyone? Indinavir is which of your antiviral drug? Which group of antiretroviral drug? That is what I wanted to ask you. Yes, anyone? Quickly. No, it is antiretroviral therapy. Very good. That is, it's a protease inhibitor. It's a protease inhibitor. Okay. And the other drugs are sulfadiazine, that is sulfa group of drugs. Then in case another drug is amoxicillin. These are the drugs which can cause the crystaluria. Can anyone tell me which cardiac condition we use this sulfadiazine? Anyone? Which cardiac condition you will have this sulfadiazine? Which cardiac condition we use the sulfadiazine? Anyone of you, please? That is in case of rheumatic fever. In rheumatic fever, what is the drug that we give? the rheumatic fever, the drug that we give is penicillin. That is benzathine penicillin we give. But if the individual is allergic to penicillin, then we give this sulfadiazine. Okay, right. So that is about the crystalluria. What are all the conditions where there can be presence of the crystals in the urine, right? Now, so what all we have discussed, you see here, we have finished the cast, crystals, and then proteins we have finished. Now, let me try to discuss presence of RBC and WBC within the urine or within the urine analysis. Now, let me discuss about the presence of RBCs in the urine sample, right? How many number of RBCs can be there normally? That means, when will you consider it is normal? If the number of RBCs in the urine sample, if it is less than 3 per high power field, right? If the number of RBCs, if they are less than 3 in number per high power field, we consider it to be normal. When will you consider it as microscopic hematuria? We consider it as microscopic hematuria when the number of RBCs are more than 3 per high power field. That we call it as microscopic hematuria. But when will you call it as significant or persistent hematuria? Right? Significant or persistent hematuria. So significant or persistent hematuria, we use this term when the number of RBCs are more than 5 per high power field. Okay, but it should not be in one specimen. On one urine sample, we cannot consider it as. Like minimum in 3 specimens, there should be more than 5 RBCs per high power field. And at the same time, these 3 samples should not be like Monday, Tuesday, Wednesday, you have collected the samples and the number of RBCs are more than 5. No, it should be weekly once you should collect the sample, and like that for consecutively 3 weeks. Right? So for 3 weeks, weekly once. Then we consider it as persistent or significant hematuria. Like again, you need to wait for almost 3 weeks to consider it as persistent hematuria. What is the another definition of persistent hematuria is, if the number of RBCs are more than 100 RBCs per high power field, then also we consider it that is in single sample. Right? In a single sample, the number of RBCs are more than 100 RBCs per high power field. Then also we consider it as the significant or the persistent hematuria. Right? Now, the next point is, if the RBC which is there in the urine sample, if it is dysmorphic RBC, right? RBC which is there in the urine sample, if it is dysmorphic RBC means what? The biconcave shaped RBC has changed its shape. The presence of dysmorphic RBC in the urine sample tells you that it is the glomerular pathology. There is some problem in the glomerulus and the RBC are of abnormal shape. That is about the dysmorphic RBC. And when you're using this microscopy, we have low power field microscope and then you have high power field microscope. what is the role of low power field and what is the role of the high power field? Let me tell you both of these. So microscopy, if you see, you have low power field microscopy, then high power field microscopy. Low power field microscopy is that where you have, what is the role or what is the use of low power field? The use of low power field microscopy related to your RBCs is, low power field is used for examining the RBC cast, whereas high power field microscopy, that is used to detect RBCs, right? That is used to detect WBCs. That is what is the role of your high power field. Whereas low power field, it is mainly useful for examining the cast. Whereas individual RBC, if you want to check for, you need to take up the high power field. Okay, right. Then followed by that, what is the most common cause of gross hematuria? Most common cause of the gross hematuria is urological pathology. What will be the urological pathology? That is like ureteric calculi, right? Ureteric calculi or bladder calculi, right? That would be the most common cause for gross hematuria, because these calculi, the surfaces, they will be rugged surfaces or rough surfaces, and they can tear the ureter or the bladder, causing the hematuria. Then the other important condition where you will have gross hematuria is renal parenchymal pathology. Okay, urological and renal parenchymal pathology, you will have the gross hematuриas. But most common will be urological. Most common will be the urological. Okay, and the next important is what is the most common glomerular cause for the gross hematuria? The glomerular pathology for the gross hematuria, that will be IgA nephropathy. Right, that will be IgA nephropathy. So IgA nephropathy is the most common glomerular cause for the gross hematuria. Okay, now after having discussed about the story of the RBCs, when do you consider normal, microscopic, significant, and dysmorphic, right? Then we should know the change in the color of the urine. If it is red in color, what does we need to consider? So the causes of the red urine. So can anyone tell me which drug intake can cause red urine? Anyone? Causes of red urine. Not rifampicin. Rifampicin, orange colored urination will be there. Yes, Hari and Monisha, it will be, and even Jacob. So it will be orange colored urination with rifampicin. Any one of you? I'll tell you the drug. Please tell me what is the drug. Clofazimine. What is clofazimine? Any one of you? What is clofazimine? Yeah, so it is an anti-leprotic drug, right? Yes, which will cause the red colored urine. Then porphyrins. Even this will cause the red urine. Okay. Now, what you have done is you have taken that red urine sample and you have done a dipstick in order to check if there is any presence of RBC. Right? You have done a dipstick test. Right? And this particular dipstick test, that urine sample, red color urine, you have done a dipstick test and you found that there is presence of RBCs in the dipstick test. Then what you have done to this particular sample, see, red color urine, it can be hematuria, it can be myoglobinuria, it can be hemoglobinuria also. We don't know what is the cause. To make out that, you need to do centrifugation of that sample. Right? Centrifugation should be done. And what should be the rate at which the centrifugation is done? That is at a rate of 1500 rotations per minute for 5 minutes. Right? For 5 minutes. Now, after centrifugation, right? After centrifugation, if the supernatant that is on the surface, if the supernatant, if it becomes clear, then it is considered to be hematuria. Right? It is considered to be hematuria. If suppose, if the supernatant, it is red, the supernatant is red, in spite of centrifugation, there are two options. There can be two things. Either it could be myoglobinuria, right? Or it could be hemoglobinuria. Right? Either myoglobinuria or hemoglobinuria. And keep this sample for 3 hours. Right? Keep this sample of the urine for 3 hours where the supernatant is still red. If suppose, right? If suppose, if there is clearing of the test tube, right? If there is clearing of the test tube after 3 hours, then we consider it as myoglobinuria. Right? And in spite of 3 hours, right? In spite of 3 hours, if the test tube is still red, right? In spite of 3 hours, if the test tube is still red, it is considered as hemoglobinuria. Okay. So if the test tube is completely cleared within 3 hours of making the sample to stand still, it is myoglobinuria. But if it is still red, then you should consider it as the hemoglobinuria. So that is a workup if you are getting a red urine sample. Right, yes. That the dipstick test can be positive even for your myoglobin and as well as hemoglobin also, right? Because in the recent times, right, the dipstick tests have been a lot of improvisation. The dipstick tests are not just the dipstick tests, they are not just only analyzing the proteins. The dipstick tests are able to analyze the blood, able to analyze the pH, able to analyze the glucose, ketones, proteins, bilirubin, nitrates. These all things the dipstick tests are able to analyze in the recent days. Okay, is that clear, Jacob? Right. Now, after having discussed about the story related to red urine, I will give you different scenarios. Now, what could be the underlying diagnosis? Like, for example, the patient is having, or the individual is having hematuria. Along with that, there is pyuria as well, or right, either pyuria or bacteriuria. What you need to consider this as? This you need to consider it as the urinary tract infection. This you need to consider it as urinary tract infection. For suppose you take another scenario. So this is like I'm giving you a crux of the question, right? He will give you a big clinical scenario like fever is there, so on and so forth. But on urine examination, there is hematuria and pyuria. Think of urinary tract infection. The other scenario is, right, the patient is having hematuria, right? Along with hematuria, there is presence of RBC cast, right? Or there can be dysmorphic RBCs. Right? Or there can be dysmorphic RBCs. Along with that, proteinuria is there. Okay. Then what is the underlying diagnosis, or where is the pathology? That is in the glomerulus. That is glomerulonephritis. Why are you consider it is the pathology in the glomerulus? Because you have the presence of dysmorphic RBC. Then you should consider it as the glomerulonephritis, right? And I'll give you another scenario. Another scenario is, does anyone know what you mean by this word Katayama fever? Yes. What are the scenarios where do you get this Katayama fever? Very good, Jacob. That is, yeah, that is in case of schistosoma, acute schistosomiasis. You get this particular, the Katayama fever. Okay. So this schistosoma infection, this can cause hematuria. Along with hematuria, there will be also fever. So now, Jacob, tell me, because it's a parasitic infection, which cells should be there along with the hematuria, along with the RBC? Along with the RBC, what are the very good, excellent? That is eosinophils. Okay, that is eosinophils. Okay, presence of your hematuria fever along with eosinophils. Think of this schistosoma. And when you do a urine examination, you will be able to observe the eggs of the schistosoma. And this particular eggs, they have a terminal spine. I'll show you that egg. Right, this particular eggs will have the terminal spine. Okay, so you see that. Okay, so this is the terminal spine of schistosoma hematobium. Right, schistosoma hematobium. Okay, right. Then next followed by that, until now what all we have discussed is the abnormal cell RBCs we have discussed. Now let me discuss what are the various forms of the WBCs that can be there, right? So the various forms of the WBCs that can be there is eosinophils, that is eosinophiluria, right? What are the causes for the eosinophiluria? The causes for the eosinophiluria, that includes atheroembolic diseases, right? Then allergic interstitial nephritis, right? Allergic interstitial nephritis. So these are the two conditions where you have WBCs, which is nothing but the eosinophils in the urine. Now, you take this eosinophil. In order to detect the eosinophil in the urine, what is the stain that is being used? The stain that is being used for analyzing the eosinophil in the urine is Wright and Hansel stain. Okay, Wright and Hansel stain. That is what is being used for picking up the eosinophils within the urine sample. Then you take this atheroembolic diseases. See, the history will be very clear regarding these atheroembolic diseases. What will be that history? Like, a patient with coronary artery disease has undergone coronary angiogram through the femoral route, and angiogram or the angioplasty was done, which was like showing the pathological lesion in the left anterior descending artery, and that left anterior descending artery has been stented, and the patient is fine after the procedure, has been shifted to ICU, and next day it was found that the individual has gone into an acute form of renal shutdown. That means there is no urine output in the next day. This will be the classical picture. Then further, on examination, there is presence of like purpura in the toes and fingers, and urine examination showed the presence of eosinophils. This will be the classical history. What is that you need to think of? Atheroembolic kidney disease in that patient. Now, why? Doing coronary angiogram, why the individual should go into a state of acute kidney shutdown? See, whenever you are passing when you are doing angiogram, what is that you need to do? You need to puncture the femoral artery, pass the catheter from the femoral artery to iliac to the abdominal aorta, from abdominal aorta to the descending arch, and then ascending aorta. From the ascending aorta, you have the coronary sinuses into which you enter into right coronary and as well as the left coronary sinuses. Okay. Now the point is, whenever you are passing the catheter, you have that atherosclerotic plaque in the vessel wall, either in the abdominal aorta or descending aorta or in ascending aorta. You have that atherosclerotic plaque. When you are passing the catheter, there is chance that your catheter can rupture, right, or can erode that atherosclerotic plaque which is there in the abdominal aorta. And once this atherosclerotic plaque, if it is like fragmented, the fragments, they emboli to renal artery, leading to acute kidney injury. That is what is the and now the point is, this atherosclerotic plaque fragments, they will initiate the allergic reaction that will result in eosinophilia. That will result in eosinophilia. Okay. So atheroembolic diseases, it usually follows the coronary angiogram. And these patients, they have acute renal failure. And you will notice that on examination, there is presence of purpura over the toes and fingers. Right? Purpura over the toes and fingers. That is what you will observe in atheroembolic diseases. Right? Where it is done after the coronary angiogram. Then allergic interstitial nephritis, also you have the presence of the eosinophils in the urine sample, and it is acute kidney injury due to antibiotic intake. Right? And what is that particular antibiotic? Like, for example, cephalosporin. Okay, so that is about the presence of eosinophils. Two conditions: atheroembolic diseases, then allergic interstitial nephritis. You can have the presence of eosinophils in the urine. Then, so until now, like, you just see what we are discussing. We have discussed the RBCs over, WBCs over, cast over, crystals over, right? Proteins over. Then let me discuss about the fat bodies. So what are the conditions where you have the presence of the fat bodies? You see, this is the oval fat body, right? Where do you have this oval fat body? That is mainly in case of the nephrotic syndrome. So oval fat bodies, it contains lipids. So whenever there is lipiduria, you have the presence of the oval fat bodies. What are the conditions where you will have lipiduria? That is in patients with nephrotic syndrome, because in patients with nephrotic syndrome, there is hyperlipidemia causing lipiduria. Then long bone fracture, where there can be fat embolism syndrome. Then thoracic duct obstruction causing chyluria, right? These are the conditions where you can have the presence of the oval fat bodies, or nothing but the presence of the fat in the urine. Then followed by that, we have the epithelial cells, which can be arranged in the form of Maltese cross appearance. So what are the conditions where you have the presence of Maltese cross appearance in the urine? Okay, first of all, you should understand what is this Maltese cross. First of all, you should understand what is this Maltese cross. This is what is called Maltese cross. So this is like the exact picture of the Maltese cross, and this is the urine sample. First of all, what is Maltese? Does anyone know what is Maltese? You know, Maltese, it is a symbol of protection. It's a symbol of protection. That means, like a firefighter wearing this badge with Maltese cross, right? A firefighter wearing this particular badge containing Maltese cross, you know what does it represent? It represents that he is willing to lay down his life, and he is able to sacrifice his life for the fellow men. That is what is called Maltese cross. Okay. Now, what are the conditions where you have the presence of the Maltese cross in the urine sample? Maltese cross, actually, there are like in multiple samples, you can have this Maltese cross. For suppose, in the urine sample, you have the Maltese cross. The conditions where you can have is in patients with nephrotic syndrome, you can have this Maltese cross, right? In Fabry's disease, you can have the presence of Maltese cross. Fabry's disease is due to what? Right? So this is due to GLA gene mutation. Right? So this is due to GLA gene mutation. Right? This GLA gene mutation in Fabry's, that will cause alpha galactosidase deficiency. Right? Alpha galactosidase deficiency. Okay. Next. Now, that is in the urine sample. What are the conditions where you have Maltese cross in the peripheral smear? The Maltese cross in the peripheral smear, you have that in Babesia microti. It's an infection, right? What is the question asked on this Babesia microti is, what is the vector which will transmit this Babesia? That is Ixodes tick. That is a vector, right? So Maltese cross in the peripheral smear, you see that in case of the Babesia microti, whereas the CSF sample showing the Maltese cross, that you observe in cryptococcal meningitis. Right? In cryptococcal meningitis, you have the presence of the Maltese cross, right? Now, so this is about the story of Maltese cross. But in the urine sample is what is the question for us, which is very important point of the discussion. Okay, next. Now, then another important abnormality within the urine sample that you need to know is the color of the urine sample. So we have various colors of the urine. So if you take the various colors of the urine, you should know. Yeah. So you take the color of the urine sample. So color of the urine sample, if you see, based on the color, right, we have the various colors of the urine. One is the pink urine. Pink urine, you have that in case of a person taking iron chelating agent, that is deferoxamine, right? Then you have another important terminology called pink diaper sign. What are the conditions? I mean, what is that? Where is that you have the pink diaper sign? That is caused by an infectious organism, right? What is that pink diaper sign? Pink diaper sign is like mother will come and tell to the doctor saying that my baby, like after urinating, and when I'm discarding the diaper, I can see the pink color within the diaper, which is nothing but pink diaper sign, and which is caused by an organism that is Serratia mascarens, right? Then conditions where you have red urine. Red urine, just now we were discussing, that is individual taking clofazimine. Right, individual taking clofazimine, you will have red urine. Conditions where you will have cola colored urine. So cola colored urine, you have that in glomerulonephritis, where you have the hematuria. Conditions where you have black color urine. So black color urine, you have that in hemoglobinuria. Okay, so hemoglobinuria, depending upon the number of or the quantity of the hemoglobin, it can be dark red in color or it can be black in color. So where do you have hemoglobinuria? That is paroxysmal nocturnal hemoglobinuria and paroxysmal cold hemoglobinuria. And what are the conditions where urine turns black on exposure to air? That you see that in alkaptonuria. Okay, so in cases of the alkaptonuria, you will observe that there is the urine turning into black on exposure to air. And how can this be prevented? So the prevention of turning into black, it can be done by supplementing vitamin C. It can be done by supplementing vitamin C. So this is about the color of the urine. Okay, so this completes the discussion of the abnormal urine analysis, right? So what all we have just discussed, you just see here. I'll come and revise that. We'll have a break now. So cellular elements we have discussed. Epithelial cells, that will give you that Maltese cross. Next is cast. Crystals we have discussed. Proteins we have discussed. Fat bodies we have discussed. Bacteria, you will have that in urinary tract infections or pyelonephritis. Okay, so these are your abnormal quantities or abnormal substances that can be in the urine, right? So we will just have a break now for what is the time now? 10:25. So we will just have a break until 10:40. right? We will come back and discuss the exact renal pathologies now: acute renal failure, chronic renal failure, nephrotic syndrome, nephritic syndrome, and so on and so forth. But before that, I will revise this topic. You also just go through that. I will revise this topic before starting the next topic. Okay, so just take a break for 15 minutes and then we will be back.